of all, I would like to thank you to Dr. Dean, Dr. John, and Yunzi, our company, for organizing this very meaningful webinar and having me in this webinar. So I'm Dr. Ye, and today my topic is multimodal layer approach for acne scar. Let me start with the overview of acne. The prevalence of acne is about 9% of world population. It is common in 80% of teenagers and 30% of adult women. Unfortunately, many acne patients develop acne scar. For my acne, 28% could develop scar, but for moderate to severe acne, 50 to 70% will get scarring. We all know that acne can cause anxiety, depression, low self-esteem, and even increase the risk of suicidal thoughts. This is classification of acne scar. Acne scar can be classified into pigmentary changes and contour irregularity. Hypertrophic scar account for 20% and atrophic scar for 80%. Then we can be, atrophic scar can be self-classified into ice pick, bow scar, and rolling scar. How to approach acne scar? The first thing is to choose the right patient. Patients should have realistic expectation. I always tell my patients, I can improve your scar, but I cannot remove them. For improvement, I tell them you can expect 50 to 70% improvement, but never 100%. I also tell them the result may take times and you can see the result only after a few months. Please remember there are patients with their body dysmorphic disorder, so don't do it if you have some doubts. In my opinion, the acne must be stable, so we have to treat the active acne before the acne scar management. Other considerations may be patient skin type, previous procedure, and patient budget. How to approach pigmentary changes? PIH and PIE may be secondary to long-standing inflammation or may be due to picking, scratching, and squeezing habit of the patient, or maybe both. For management, we can give topical bleaching agent, or we can do chemical peeling, or if my patient have a budget, I could use pigmentary laser, vascular laser, or even I can try with the aerosol. What if we don't have an expensive laser machine? We still can do the chemical peeling, which is cheap and effective. Chemical peeling can give the best risk-benefit ratio of all acne scar treatment. It can be used not only for PIH, but also for PIE. My approach is basically I started with the salicylic and glycolic acid if it is only acne. If there is a PIH, I usually do TCA peeling. This is my patient with PIH and PIE. For this case, I use TCA and salicylic peeling. This is another case with PIH and atrophic scar. For this case, I use TCA and glycolic peeling for 6 times. How to approach atrophic scar? We all know the management of atrophic scar is very challenging to us. There is no single treatment which is the best for all scar type. Different scar type respond to specific treatment. That's why we wonder what if we combine with this treatment modality. It could smooth acne scar more effectively, or it could heal faster, or it could tackle tricky conditions. The question is how to combine these treatments. We can go for tailored approach according to different types of acne scar, or we can go for layer approach. It means we are trying to treat different layer of the skin from the bottom to the top. We can start with the subcision. to break the scar adhesion from the bottom. Then we can add biostimulator to stimulate the collagen synthesis at a deeper level, and then followed by laser resurfacing or chemical peeling for superficial scar. And finally, we can apply PRP or azozole for wound healing enhancement and skin quality improvement. Let me start first with the subcision. Basically, subcision is a short form of subcutaneous incisional surgery. It can improve all types of atrophic scar. The concept is we are trying to break fibrous bands and we are trying to prevent retearing of the scar tissue. There are many methods for subcision. We can use no-core needle or we can simply use hypodermic needle. In my practice, I usually use a hypodermic needle, which is less invasive and easily available in the market. We can also use cannula, especially if the scars are less fibrotic and rolling scar. This is classic subcision method. This method is mainly used for Bosca scar. In this case, I use 22G hypodermic needle. My technique is I'm trying to break the scar adhesion by two different motions, forward and backward motion and side-to-side motion. You can hear the snapping sound when the fibrous bands are broken. There will be multiple puncture sites due to individual scars are treated separately. There are a few side effects with the classic subcision, which are not very serious, like erythema, edema, bruising, and tenderness. My approach was subcision using blank cannula and biostimulator. This can be used for rolling scar and less fibrotic scar. In this case, I use 21G blank cannula for subcision and biostimulator injection. Firstly, I did the subcision to cut the scar adhesion, to lift up the scar tissue, and to make a space for biostimulator. After that, I inject the biostimulator using retrograde fanning technique. Biostimulators are very trendy these days. Biostimulators are injectable with the ability that improve skin texture, volume, and overall appearance by stimulating the body's natural production of collagen and elastin. The mechanism is biostimulator create subclinical foreign body reaction that leads to regenerative wound healing process. In other words, we would like to get control and predictable inflammation. However, we have to understand that if the inflammation is too low, there will be no result. If the inflammation is too high, we will get granuloma. Biostimulator can be classified into inflammatory biostimulator and non-inflammatory biostimulator. PLA, PDLA, PCL, PDO, and calcium hydroxyapatite are widely regarded as biostimulator, but PN and HA are also in the category of biostimulators. This is Korean study using PDLA and microneedle RF for acne scar. In this study, they applied the PDLA first, followed by microneedle RF every 4 weeks for 4 times. As a result, we can see 35 to 80% improvement of the acne scar. This is my case of rolling scar. For her left side, I treated with the PDLA without laser. And for her right side, I treated with PDLA combined with the CO2 freshener laser. And I compared the result. And I found that the right side, which was treated with PDLA combined with the CO2 laser, have a better result than the for her left side. For this case, I did injection of polynucleotide for 3 times. I saw the improvement and just only after 2 times. However, the result became less visible over time. That's why patient satisfaction was 6 out of 10. Laser resurfacing. Laser resurfacing is a gold standard for acne scar management for many, many years. Usually we use CO2 or RB inject laser for laser resurfacing. The mechanism is we create thermal injury by using energy-based device, which initiate regenerative wound healing process that leads to collagen synthesis. Nowadays, we usually combine with the exosome to enhance the healing process and to reduce the side effects. In Myanmar, majority of people are skin type 4 or 5. That's why we have limitations of using energy-based devices. In my practice, I usually use moderate fluents with a low density to prevent the risk of PIH. These photos were taken in 2016 and 2017 at my clinic. He has ice pick, Oscar, and rolling scar. I did CO2 fractional laser for 10 times. You might appreciate the improvement, but I believe if I could combine with other treatment modality, I could give better result for him. Azozone. Everyone talk about azozone. In the past, we thought azozone were a waste product of the cell. But nowadays, we realize that azozones are essential for cell-to-cell communication. Azozones are very small, so the good thing is they can easily absorb into the dermis.